Good evening and welcome to the second evening of the annual ISEH Sports and Exercise Medicine 2025. We had a tremendous evening last night and we look forward to another fabulous evening tonight, where we're going to be discussing expert care for the collapsing athlete. Now, athletes who either partially or fully collapse or lose consciousness when undertaking competitive sport is obviously challenging and is a pretty scary situation. It should be treated as an emergency situation and needs immediate medical assessment and a logical approach to onward management. We are very lucky tonight to bring together three internationally recognized experts in emergency medicine, cardiology, neurology, and respiratory medicine to understand how they manage the collapsing athlete and help you to understand how to manage both the event of when it happens immediately and also what to do moving forward. The format of this evening, we're going to be starting with a patient story, and I'll come on to that in a moment. We're then going to be moving on to looking at emergency medicine. Then we're going to be moving on to cardiology, then respiratory, and then moving on to exercise-related exertional collapse in the heat. We're very lucky to have our technicians in the background. We want you and encourage you to use Slido for Q&As. We're going to be doing a live Q&A with all the speakers at the end of the session. This session will also be recorded, and we'll put that up onto the ISEH website for you to distribute to your colleagues in your network. There is a hashtag. I'm very old, and my daughter will laugh at me. But it is ISEH SEM with a small c 25. So that's ISEH SEMC 25. And please do what you need to do if you are socially media savvy. Clearly, I am not. So we'll start this evening with an interview with our Olympic gold medalist, Jonny Brownlee. And we'll hand over to Professor Jim Hull. I'll introduce him a little bit later on. But Professor Jim Hull will be managing the interview with Jonny. Thank you and welcome.
So look, it's my pleasure to welcome you to this symposium, and we thought it'd be really useful to start off with by sharing an athlete's story in the context of a collapse or a near collapse, certainly in the context of elite sports. So we are incredibly privileged to start this symposium with this very special guest athlete, Jonny Brownlee. Will need no introduction to many of you who have joined the symposium this evening. He's an Olympic champion, Olympic medalist over 3 successive Olympic Games, multiple world champion, triathlete, and obviously a great ambassador for British sport. So Jonny, first of all, thank you very much indeed for joining us this evening.
Thanks for having me. Yeah, it's going to be an interesting talk about this from a different point of view. Obviously, I've won lots of medals, but I think I'm actually more famous for collapsing. So yeah, it was an interesting time afterwards.
So yeah, so listen, we're going to take you back to September 2016, Mexico.
And this is worrying. Oh, and he's starting to slow. And there is a little way to go. There's half a K to go. And Jonny is running out of time and is losing his sense of direction. This is worrying. Oh, goodness me. This is a horrible sight. Jonathan Brownlee has lost it now and has staggered to a stop at the side of the course, and Alistair's stopped to help him along. And Alistair is going to try and carry his brother home. Dramatic scenes in Cozumel as the Olympic champion carries his younger brother towards the podium.
Oh my God, I cannot believe what we are seeing here. Matt, is this allowed? Is he allowed to help his brother? You know, is that part of the rules? I'm not too sure. We've never seen anything like this before.
Unbelievable scenes. Unbelievable scenes in Cozumel. The Brownlee brothers arm in arm, but it's not by way of celebration. Henry Schoeman's celebrating. He's going to win this race in Cozumel out of nowhere. But we have to be concerned about the health of Jonathan Brownlee, and they're not even on the final stretch yet. Schoeman wins in Cozumel. The brothers are coming home arm in arm to finish in second and third, but Jonny can hardly stand. And Alistair is having to drag him across the line and pushing him home for second. Jonny finishes in second. Goodness me.
Talk us through that a little bit, and just talk us through what you remember, what the experience was, perhaps the build up to it, and set the scene for us.
Yeah, to set the scene, so it was September 2016, and the Rio Olympic Games was obviously August 2016, so that was the main aim for the year. I had got silver medal in there, and in Rio, it'd all gone well. We'd done some heat preparation into Rio because we were worried about it being quite hot. And then the World Series continues post Rio, so I had a chance to become world champion. So I went to Mexico off the back of a long season, but we were in Claremont in Florida for about 2 weeks before, again getting some warm training in with the idea of topping up my heat training from pre-Rio. So flew there to Mexico. Obviously the conditions were ridiculously hot. That's the first thing that I remember being there. I remember being in the hotel for probably only 4 or 5 days before the race, and it's simple stuff like walking to breakfast. It was outside. By the time you got to breakfast, you were already covered in sweat. I'm thinking this is gonna be a hot, hard race. We were obviously I knew about heat exhaustion. I had actually suffered from heat exhaustion in April that year, so April 2016 on the Gold Coast. And in many ways that was actually worse, and there's a lot of time that I can't remember what happened in that event, but I have heard from coaches afterwards that basically I remember feeling a bit strange in April, getting across the finish line, and then apparently I was left in this warm, meant to be an ice bath, but it wasn't. By the time we got there, it was a warm bath of water for apparently about half an hour, and I got very little medical treatment. They had no ice or IV drips or anything. So I can't remember any of that. All I remember is hearing stuff afterwards of our coaches trying to get into the medical area with ice that they got from local restaurants to kind of make me come round. And what I remember about the April one was eventually coming round and looking at my body, and I just looked so skinny and drained and being like, what has happened to me? It took me a while to come round for that. So obviously going into Rio, I was worried about the heat, so I made sure I was prepared for that. But yeah, then Cozumel came along, and like I say, it's a chance to become world champion. All I needed to do, if I won, I had to make sure that a Spanish guy, Mario Mola, didn't get on the podium, and that'd be it. I'd be world champion. So the heat was talked about. Obviously, we knew it was gonna be hot. Had Alistair there to kind of help me round on the bike, and we had a perfect swim. We were ahead. I remember the first bit of swim being hot on the sea, and then we came into the port, and it literally just been a bath. Like thinking it's the hottest water I've ever swum in my entire life. The bike went perfectly. Our front group worked quite hard. We had a gap. It was all going brilliantly for me to become world champion. I remember starting on the run, thinking again, this is going to be a long 10K. Don't try and win it by a minute. Just try and win it by the least amount possible. With about a 5K to go, I thought, right, let's just go for it now. Let's get this world championship won. Took off, got a gap on Henry Schumann from South Africa and Alistair quite easily. Thinking, right, this is perfect. 5K to go. One lap to go is 2.5K to go. Again, brilliant. Thinking, I'm not feeling too hot. And then my memory is quite patchy. I remember with about 2K to go, my skin feeling cold and thinking, oh, I know a little bit about heat exhaustion, and I know that's not good when your skin starts to feel cold and a bit shivery. But I thought about 2K, absolutely fine. And then with about 1 kilometer to go, I went around a U-bend, and my legs started to go a bit funny, and I couldn't really control my legs. I felt like I couldn't control the corner. I hit the curb. I'm thinking, okay, that's not great. But this point, I was still conscious. Then the only memory that I've got, apart from watching it back, which I try and avoid doing, is a few bits of it, which was I'm getting to the water station. There's a guy in the water station trying to kind of lean on him to think, right, I can't hold myself up, so if I lean on him, I'll be fine. Then keep on going, and then Alistair grabbing hold of me, and I remember thinking, please just leave me now, I can't make it. Alistair kind of shouted at me, come on, and then I remember crossing the finish line and hitting the ground, and then I have absolutely no memory. There's probably half an hour gone. and then I came round. And I remember having this really weird feeling when I came round. It almost, I came alive from my toes upwards. Like it felt like I got movement in my toes and all the way up to my head. I'm thinking, all right, I'm alive again. And then I phoned my parents. My parents are both doctors, and obviously they're incredibly scared of it all, scared of the whole thing. They were at home, and I phoned my mum, and she just burst into tears. And then went to hospital, and was on a bed and got an IV drip, and eventually kind of came round. And then my only other memories are, getting back to the hotel and thinking, what's happened, being left in this hotel room, being a bit like, oh, am I okay to be left on my own? Well, I'm not sure what I can do. I'll just go to sleep. Waking up a bit hungry in the middle of the night, trying to find room service because I was hungry, but there's nothing to eat. And then, wake up in the morning, and then the kind of whole media storm. So, yeah, that was the kind of summary of it all.
Wow. And when you think back about it now, I mean, compared to your April event, were there similarities that you identified that you thought, this is the heat stress that I saw coming, especially when you went into the very warm water in the swim section, or what did you think about that?
Yeah, well, I think the similarities were definitely, obviously, the hot environment is a simple one. I probably wasn't as well prepared for them as I should have been. I hadn't really, before April, I hadn't really done any kind of real heat stuff. Into the September one, I was relying on my Rio heat prep, really. I hadn't really done a proper heat block then. I've got far better knowledge of what heat kind of training involves now. I think also a bit tiredness going into them both. And the April event especially, we did a really hard training session about 8 days out where I was absolutely flying, but it was really hot and hard. And then the October one, the September one, the Cozumel one, it was the end of a long year, and I think my body was a bit tired. And then also the last one was probably pacing as well. The April one, I definitely tried to follow the guy in front of me, who beat me in the end, and then ended up blowing up. The Cozumel one, I should have aimed to win that race by 1 or 2 seconds, not trying to win it by 30 seconds. For the next 18 months, honestly, I felt that my body was capped at 90%. Every race I did, I would get to a point, my body would go, right, that's enough, we're not going there again. And I'd cross the finish line and go, I'm not actually that tired, but I couldn't have gone any harder. The actual event was scary, but I can't remember it. So it's not like a traumatic event that you went through and you think you wake up at night scared about or anything. It was actually quite easy for me because the 2 minutes are just gone. I think it's a physical thing, and the body is an incredible thing. And I genuinely believe that my body just capped and thought, it's not natural to do that. Why are we ever going to do that again? What's the point? And it just stopped me before I could get to that point.
Listen, thank you so much for your story and your recollection. It's lovely to share that, and it sets the scene beautifully for the talks that will follow this evening, talking about heat, talking about cardiac and other aspects of collapsing athlete. Wishing you all the best for the rest of your season.
Thanks a lot.
Well, thank you, Jonny, and thank you, James, for that fabulous patient experience. It really is quite a scary situation to have to deal with on a personal level. And I can only imagine the medical team at the end of the finish line having to deal with a collapsed athlete. Which leads me on very nicely to introduce Professor Olaf Schumacher. He is the head of internal medicine and emergency services at Aspetar Orthopedic and Sports Medicine Hospital in Doha. He has been the chief medical officer for several major sporting events, including overseeing the medical care for the FIFA 2022 World Cup in Doha. I've personally worked with Olaf in the medical tent at the UCI Cycling World Championships and the World Athletics Championships in Doha, where we had a number of collapsing athletes. In fact, I think in the marathon and race walk, if you forgive my rough statistics, about half didn't complete due to exertional heat-related illness, and there were several collapses in the medical tent. He has a very strong interest in physiology. He's made significant contributions to the Athlete Biological Passport and is a key advisor to the International Committee and the World Anti-Doping Authority. It's a great pleasure to introduce Olaf. He's going to be discussing immediate response and event preparedness.
Hello, and thanks for having me to let me open the session. I will start a little bit on the immediate response and the event preparedness and leave the real medical care of the collapsing athlete to my colleagues. In fact, the management around a collapsed athlete is almost as important as the correct treatment for the condition. Now, I'm going to start with some thoughts about around the causes of collapse. We'll talk a little bit about the logistics on how to take best care about the collapsed athlete. Then what to do in case, or let's say as an immediate response, how to deal with that, kind of a few steps. And we talk a little bit about prevention, because obviously the best collapse is the one that never happens, and we can prevent it. Let's do so. And we'll end with a short summary and some take-home messages. There's obviously a lot of stuff for 20 minutes, and I just scratched the surface. My colleagues will go much more into depth, and obviously you can ask the question that you like later in the Q&A session. Now, let's start with collapses. You know, collapses in sports are incredibly common. You know, summer sports, winter sports, individual events, mass events. At the top, for example, you see the finish line of the Cycling World Championships we had in Doha in 2016. At the bottom, you see some track and field competition. And on the right, you see like a Tour de Ski arrival, you know, many collapsed athletes. It's so common that there's even an Instagram page ranking the collapsed athletes, you know, so there people can post collapses and photos and see which one is the most dramatic. So go check it out if you want some entertainment in terms of collapse. Now, the good thing is that most of the collapses are actually quite benign. Exercise-associated collapses, you see the ladies on the left at the finish of the cross-country world championships in Kampala some time ago. They didn't look good. They got carried away on stretches, but a few minutes later on the right-hand picture, they're actually up. Most of them are sitting, walking, talking. So that's really good. But obviously, there's also the bad stuff. And where people can actually die. So the range of causes and consequences ranges from immediate recovery, like we saw in the cross-country, to death. The main causes are pictured here. You know, this is a non-exhaustive list. There's obviously many more, but these are the most important ones. And it's a bit overwhelming, I know that, you know, to somehow get an idea about what can cause a collapse if you're in front of collapsed athletes. So what I invite you to do is to go and identify the causes of collapse, maybe the ones that might be more important to you than others, with the risk matrix. You might know a risk matrix which comes from risk management procedures, where you somehow plot the incidence of an event on the horizontal axis, so how common is it, versus the severity on how bad the outcome potentially is, or how big the risk is. And from this, basically, you calculate the overall risk, or how you should actually prioritize the different causes. If we put the different causes that we've seen in the previous slide onto that risk matrix, you'll have something like this. So basically, everything which is kind of near or in the red area, which is either very severe or very common, is something you should have a look at, depending on your resources. The worst stuff is severe and common. You know, this is the stuff you don't want to have, because that's really dangerous. Now, if you look at the different causes that are outlined, you'll find the typical exercise-induced exhaustion, the one that we've seen in the picture, which is very common down here. It's very common, but it's not severe. And then on the other side, you find, for example, the cardiac arrest, which is not very common, but potentially lethal. So this is something you don't want either. Hyponatremia and hypothermia, two other major causes, they are very severe in case they happen, but it depends a little bit on the environmental conditions, you know, whether they happen, whether the incidence is high or low. That depends on how hot it is, you know, how the people drink and eat. Now, take-home message from this is the big three: cardiac arrest, hyponatremia, hypothermia. These are the ones in your event preparedness for the collapsed athlete you need to look out. There's obviously many more, you know. The respiratory issues, a little bit the chocolate box, you know, it can go either way. It can be relatively benign or really bad, but James is going to talk about that a little bit later. Now, the next thing when you think about the logistics of your collapsed athlete is that you need to know that a collapse can happen anywhere and anytime to any athlete. You can be lucky. It can happen on a track and field track at a big event like here at the Olympics. You have the medical team 50 meters away and the response is immediate. You can be a little bit less lucky. It's a big event, but still, it's kind of on a marathon course. There's a lot of spectators and bystanders who will kind of help you if that happens to you. But shit can go really wrong if it's in a trail run, 100K, somewhere in the mountains, your athlete collapses, not only collapses, but when he collapses, kind of rolls down the hill into a bush and you never find him again. So that's a problem. And that's a risk you have to somehow manage. Now, how to do that? The best thing is to identify the risk zones where collapses might happen, to identify risk populations, and to identify environmental risks which might influence these two. This can be done obviously through your knowledge of the sport. If you work in a certain sport, you'll have a certain knowledge about the sport, or you better. And there's also obviously some scientific literature where you can delve into. Now, as I already mentioned, the distance to the collapsed athlete can be meters in a football match or in a track and field competition, or can be many miles and many kilometers, in a trail run, in a bike race, in a marathon run. Now, so there you need to somehow identify risk zones. There's a lot of research that has gone into this. This is, for example, quite a big study, with about 500,000 participants, where they looked where marathon runners of different ages and different performance abilities hit the wall. Hit the wall, and marathon runners, when things start to go bad, and performance start to decrease. If things go really bad, the athlete ultimately collapses. Not all of the hit the wallers collapse, but a good proportion. Nobody will collapse without hitting the wall at some stage. Exceptions apply. And you can see that this, depending on the age, is pretty stable. It's usually around 30Ks. This is where things go wrong. And it is earlier, let's say the less strong runners hit the wall mark earlier. So as a take-home message from this and other research is that it usually happens in the last quarter of the race. The lower and the less experienced athletes are more prone to this earlier, and it also hits more older athletes than younger athletes. Now, looking at the bad stuff, let's say the really risky stuff, the cardiac stuff, the outcome is basically the same. This is the famous cardiac study where you can see the absolute number of cardiac arrests depending on the race quartile of a marathon, and you can see that the vast majority occurs somewhere in the last 10Ks, which is in line with this hitting the water that I just showed you. They made it a bit more detailed. They could even show that it's not only last quarter, but mostly the last kilometer and directly after the finish. The slower and the less experienced athletes and the older athletes were more prone to this. Now, how to manage this and transform this into an action plan on your race course. Now, the main thing you have to consider when you think about the event preparedness is that you have a limited amount of resources available. You don't have paramedics and doctors at libitum. You have a certain number, and you need to place them and use them as it suits your risk profile best. This is a bit, first of all, you need to identify some kind of hot spots. As you know from the research data, the last quarter, and especially the finish line and around the finish line, before and after the finish line, that is a hot spot, and you would want some coverage there. So you want some teams in that area. There's many ways to do that. I direct you to the specialized literature on the topic. There's recommendations from the marathon organizers and things like that. Then you want to have roaming medical teams, which you can somehow direct on the course, because you know roughly how old your runners are and what time the high-risk runners will run, from the studies, and you can somehow concentrate them, have them move along the course with that group. Obviously not catch everybody, but you'll somehow be in the middle of the distribution there and are more likely to catch events. And at the end, you'll have a sweeper kind of rolls up the field from the back, and looks at the back runners. That is an easy concept. There's obviously much more, and you can go in much more detail on how to organize the in-competition care. This is for a running race. If you do a trail race, if you do a cycling race where other rules apply, this obviously changes. For cycling races, for example, you cannot go back on a course. You always have to move forward on the course. I'm going to come back to that in a minute. Now, once you have done this, you obviously have to think about, if you have a collapsed athlete, how do you actually get to the athlete and how to evacuate him in case. This applies to city marathons where you have a lot of roadblocks. This applies to cross-country trail races where road access might not be easy. So you better have an idea about that and which the closest medical center will be for your conditions. Most importantly, as I mentioned, is the finish area. That's one of the main hotspots that you need to consider. Without going into details, I think a few points for you to remember to kind of address when you plan your medical care for your little event that you're running. First of all, you have to make sure that the athlete flow through the finish line is smooth, so that there's no slowdown and you don't get a condition of athletes in there, because the danger is that if the athletes slow down, athletes collapse inevitably, the finish line collapse. You don't see them because the density of athletes is too big. So you want the athletes to be a little bit spaced out. Then you want your medical facilities somewhere at the finish line. Most big marathons and big sporting events have the main medical facility around 300 to 500 meters after the finish line, because that's a good way to scoop all the finish line fatalities. This applies to running events. Now, for a cycling event, that would be a little bit different, or my recommendation would be a little bit different, because in cycling events, let's face it, in a normal cycling race, if you make it to the finish line, usually you're good. The main crashes, disasters, they occur in the lead up to the finish. So in a cycling race, because you cannot go against the course with your ambulance or something, my recommendation would be to have a sweeper team about 1K from the finish line, and then as the main bunch moves to the finish, kind of go behind the main bunch and sweep up all the casualties along the way. So that is obviously different to a running race. Then you want to know a little bit about staffing and gear. You need this AD. You'll hear more about it in the next talks. And you need to think about patient evacuation. You can see at this finish line that you see on the picture here, the roads next to the finish line are relatively empty. So there is actually some space for evacuation. So there's nothing worse than a finish line in a very cramped, small street where there's no exits. Now, the next thing, you have a collapsed athlete. Now, as you approach the collapsed athlete, there's obviously, bloody hell, yeah, of course, the first thing you need to do is you actually need to check whether the scene is safe, because like I got hit by the pillow just now, not checking if my presentation scene was safe. You might be run over by another runner and ruin his PB that he was trying to set if an athlete collapses in the race. This is maybe a little bit of lesser importance in running races because it's a bit slower. But for example, in cycling races, it's vital. So the athletes are very fast. There's team cars behind the athletes. So if you have a collapsed athlete or a crashed athlete in a cycling race, the main thing is to secure the scene. As you can see here on that picture, the car, the support car of that team has parked behind the crashed athletes, basically to protect them from other cars, motorbikes, other cyclists to crash into them. So scene safety is number one, not only for you, but also for the collapsed athlete. Now then, it's actually, the next part is actually quite easy. You go for your normal ABCs, the ones that you have hopefully learned in your life support course, to go by the normal algorithm, by check the pulse, check the breathing, call the emergency response, which you are, but then notify the rest of the command chain about the collapsed athlete. And if the athlete has a pulse and he's breathing, you're good. You think, okay, I'm fine. You know, the bad stuff is actually out of the picture. We're good to go. The athlete is breathing, he has a pulse, we're good. But then obviously it's not that easy, because now you think, what am I going to do now? And that's something that is not in the algorithm. So you have this collapsed athlete. What are the most likely things to do, and what do I need to do now? Now, there's obviously different approaches. One that I like, based on the risk matrix that I just showed you, so I showed you this little matrix. And remember, at the top, there was the bad stuff, hyperthermia and hyponatremia, and this risk matrix somehow puts the different readings regarding hyperthermia and hyponatremia into perspective and classifies this as mild, moderate, and severe. So it's a neat tool, that allows you to somehow classify this. Now, don't nail me on the absolute numbers with the temperatures. There's a lot of debate around this, but it's a very helpful tool to go for this. Now, the best stuff. Once you've done this, you have an idea on how to treat your patient, and you're going to hear about that in the next talks. The best collapse is the one that never happens. This is why, for any event that you do and you prepare for, is prevention. The first part would be some education of athletes, where you hand out education leaflets, or you include a medical passage in the race package that the athletes usually get. There's a little leaflet, and this one basically recommends a medical checkup to weed out some, some cardiac conditions that might cause cardiac arrest. There is some education on nutrition, to add extra salt in terms of hyponatremia. There's some recommendations regarding fluid intake and so on. So while athletes might not all read this, it's still it's a little start, and it focuses on the main issues that occur during these races. Now, the next part, and the prevention part, is the weather. This is something that you cannot really control, but you can react to based on the forecast for the odd day. The one of the things that impacts collapses in terms of hypothermia, hyponatremia, is the temperature. You can, and if needed, adjust the race timings. This is why many marathons start in the morning, because it's less hot. You can discuss this with the organizers. You can adapt the humidity level, the topography of the event, and obviously other hazards like pollutions or storms, like we had a few years back in the marathon in Boston. On the right side, you see the DNF rate did not finish per 1,000 runners. You see it's this J-shaped curve, and it's the lowest as the WBGT. It's kind of a measure which measures the temperature, humidity, and wind speed together and puts it into relation. And it goes up very high after a WBGT of about 13. So once you have this, you might talk with the organizer to do something with the event, because the risk of DNF on casualties is pretty high. Now, these are the points you want to look at in the prevention: the education of the athletes, the timings, the weather, and the water and cooling stations. You can adapt, because you can either add water stations or add cooling station, or remove them based on the weather, to avoid that athletes drink too much, or give them more opportunities to drink. Now, with this, I want to close with the main take-home messages that you should consider. You should know the different causes for collapse and focus on the potentially dangerous ones. If you look at your risk population, it's the older, slower athletes that are more at risk if they're close to the finish line and in challenging weather. You should distribute your resources accordingly. The immediate response is pretty simple. It's what you learn in your emergency courses. It's a typical ABC approach. Buy the book, and then you can go to the classification matrix of athlete collapses. And for your event preparedness, make sure you adapt your logistics and focus on based on the environmental conditions that you encounter on race day. Thank you very much, and I'm open for questions at the end of the sessions.
Thank you, Olaf, for a wonderful talk. And for the audience, just to remember to upload your questions into Slido for Olaf, and we will be tackling those at the end of the session. So one of Olaf's top 3 risks was cardiac arrest, and we moved promptly on to that subject. So I'm delighted to welcome Professor Sanjay Sharma, Professor of Cardiology. His interests include inherited heart muscle disease, electrical diseases, and sudden cardiac death in the young, and the translation across into sports cardiology. He has an international reputation in this field with over 500 publications and hundreds of PhD students. He's the lead cardiologist for the London 2012 Olympics, and he's the current medical director for the London Marathon. And as you know, there are many collapses every year. Tonight we're going to be looking at sudden cardiac arrest and death in athletes. Over to you, Sanjay.
Hello, my name is Sanjay Sharma, and I'm going to be speaking to you about sudden cardiac death in athletes. These are my disclosures. The objectives of my talk are to describe the benefits of exercise on the cardiovascular system, to discuss the exercise paradox and epidemiology of exercise-related sudden cardiac death. I will then go on to describe the causes of exercise-related sudden cardiac death and their detection in athletes, and finish by discussing strategies to minimize the risk of sudden cardiac death. Let's start with the benefits of exercise, which are well established. People who exercise regularly have a better body mass index and are at less risk of diabetes mellitus. They also have a better blood pressure and lipid profile. And through curbing all these risk factors for atherosclerosis, people who exercise regularly reduce their risk of a death from a cardiovascular problem by about 50% when they're in their 6th and 7th decades. However, apart from curbing risk factors for atherosclerosis, people who exercise have multiple other benefits, such as an increase in cardiac size, improved diastolic filling, and augmentation of stroke volume, which allow better tissue perfusion. At central level, they have a less stiff aorta, better systemic vascular resistance. They've got a better left ventricular compliance and increased plaque stability. At the periphery, they have increased capillary conductance and better endothelial function. They have reduced oxidative stress and are less likely to be thrombogenic. At the electrical level, they have stable electricity with a low heart rate and better ion channel expression. And overall, they have reduced systemic inflammation. And all of these factors come together to provide a high peak oxygen consumption, which is probably the best objective marker of longevity. And people who exercise regularly live longer than those who are sedentary. Here's the relationship between exercise capacity on the x-axis and cardiovascular deaths. And you will see that for every 1 net of fitness, there is a 13 to 20% reduction in cardiovascular death. And this applies to old and the young, men and women, people of different ethnicities, and people with or without comorbidities. However, it's important to discuss that exercise may trigger myocardial infarction and fatal arrhythmias in predisposed individuals. There is also emerging evidence that exercise may worsen existing arrhythmic substrates. And the death of these athletic individuals is uncommon. However, when it does affect a major athlete or a very elite athlete, these deaths are very highly publicized, or even cardiac arrest, shall I say, are highly publicized, as witnessed here with the Ericsson affair in 2020. More recently, we saw another event in our Premier League. Here's a player you see going down in quite a bit of trouble as the game goes on, and I'm pleased to say that he also survived a sudden cardiac arrest. If we actually look at the incidence of sudden death, I'm pleased to report that sudden deaths are uncommon in athletes. But when they do occur, they often occur in young individuals. The mean age of death in young athletes, these are athletes aged under 35 years old, is 18 years. There's a high male to female ratio of 9:1. There's a 5-fold greater risk in athletes of African or Afro-Caribbean origin. And some sports, these dynamic start-stop nature type sports, such as soccer and football, are associated with a higher risk than the sort of moderate continuous exercise or other endurance, long-term endurance, long-distance endurance sports. And over 80% of these deaths occur during exertion. And I'm sad to say that 80% have no warning symptoms, so we need some form of screening procedure to identify them. If we look at the incidence of sudden death, you will see that it varies a lot from 0.4 per 100,000 to 2.6 per 100,000. And this huge difference in the incidence is really governed predominantly by the way the numerator is collected, i.e. the number of people that have died, and how the denominator is estimated, the number of people that are being investigated. It's also important to remember that deaths are governed by many demographic factors, such as the age of the athlete, the sex, the ethnicity, and the sporting discipline. If we look here at the demographic and compare it with the incidence of sudden death, then we'll see that in women, death rates are less than 1 per 100,000. If we then examine males, that goes up to 2 per 100,000. These are adult males. If we then look at adolescent males and black athletes, that goes up to 8 per 100,000. And if we look at certain sports such as football and basketball, and we look at the ethnicity as well, then the risk of a sudden death in a black football player or a black basketball player is 20 per 100,000. That's 20-fold greater than it is in a white female athlete. So the demographic is also important. If we look at the conditions that predispose to sudden cardiac death, you will see that these are due to a diverse spectrum of inherited, congenital, and acquired diseases. If we look at the literature worldwide, then the cardiomyopathies are considered to be the leading cause of sudden death, with hypertrophic cardiomyopathy being the leading cause in the United States until recently, and arrhythmogenic cardiomyopathy leading deaths in certain parts of Europe, such as Italy. But if we look elsewhere, you'll see that deaths can be due to congenital anomalous coronary arteries, aortopathies, valve disease, and even acquired conditions such as myocarditis. The prevalence of diseases implicated in sudden death in the young general population in the UK and in the US is about 0.3%. So that 1 in 300 young people harbour a condition that could potentially cause an exercise-related sudden cardiac death. And if we look at death rates in people exercising with these conditions compared to people who don't exercise, then exercise increases the risk by between 3 to 5-fold in individuals with these conditions. And hence, if we look at the sudden death in sport, it's governed by several demographic factors. There are modifiers such as the arrhythmogenic substrate, genetics, maybe performance-enhancing agents, infection, unaccustomed activity, and possibly the environmental climate. And the triggers in these individuals may include adrenergic surges during exercise, dehydration, electrolyte imbalance, acid-base disturbances, and in middle-aged and older individuals, the rupture of an atherosclerotic plaque. And all of these could result in some cases in either myocardial infarction or ventricular fibrillation. So given that deaths, although deaths are rare, they do cost multiple decades of life. They're often due to conditions that can be diagnosed, for which there are several therapies. Hence, there are multiple incentives of identifying these, including mandatory cardiovascular evaluation in elite sport. In those that practice grassroots sports, there are certain charities offering cardiovascular assessment. So what does preventive strategy include? This includes athlete education, active screening, and also the availability of automated external defibrillators. For most of my talk now, I will discuss active cardiovascular screening. I've already told you that deaths in sports in young people are uncommon, yet there are multiple people exercising. If we look at the sort of tests that are available to us, going from history, examination, ECG, echo, and forward on to more intensive or more detailed assessments such as MRI, then the more tests we do, the greater our diagnostic yield. But that is at the cost of more finances required. And clearly, if deaths are uncommon and we're doing all these expensive tests, then one could argue that screening becomes cost prohibitive. So whatever we do in these uncommon situations has to be something that's relatively cheap, easily available, and easily interpretable. That leaves us with history, examination, and the ECG. The history is useful, but I told you earlier that 80% of athletes that die have no warning symptoms. Physical examination has a role to some extent, but most conditions that are implicated in sudden cardiac death in young people do not have any physical signs. The ECG is useful because it can identify electrical diseases such as Wolff-Parkinson-White syndrome, Brugada syndrome, and the long QT syndrome. In our experience of 357 consecutive athletes that died, of whom 92% were male and 69% were competitive, you will see that the pie chart that's the largest is the red one. And this is where we did not find an obvious cause of sudden death. If one investigates the first-degree relatives of these individuals, then we find that in about 40% of these individuals, one of their family members will have an inherited ion channel disorder, suggesting that in many cases where nothing is identified at post-mortem, the death is often due to an inherited ion channel disorder. Apart from identifying electrical diseases, the ECG is also effective in identifying individuals with cardiomyopathy. You'll see here that 95% of people with hypertrophic cardiomyopathy have an abnormal ECG, 80% of those with ARVC, and 75% of those with DCM have an abnormal ECG. However, there are concerns about screening. One is the low incidence of sudden cardiac death, the high number of false positives, concerns related to false negatives, the cost, and other issues. Although sudden death is uncommon, it does affect it does cost multiple decades of life. So on ethical grounds, one could justify screening these young individuals. But let's talk about false positives. We know that athletic screening is associated with a plethora of electrical and structural functional changes that enable the generation of a large cardiac output for a prolonged period. Some of these changes may overlap with diseases implicated in sudden cardiac death, especially in large adult men that engage in endurance sport. We also find that if we look at athletes of African or Afro-Caribbean origin, these are the ones in the blue bars compared to white athletes or in the red bars. If we look at the ECG changes, we find that black athletes have an 8-fold greater incidence of an abnormal ECG compared to white athletes. Although in many cases, these black athletes' ECGs may be ethnically mediated rather than due to disease. So expertise is required when investigating such individuals. Over the past 6 or 7 years, we have identified ECG criteria that clearly identify those athletes that we consider normal. These take into account ethnicity, age, endurance sport. These are in the green. And in the red, we've identified ECG changes that are typically abnormal. And in the middle, we've got borderline ECG changes consisting of atrial enlargement, axis deviation, and complete right bundle branch block. In the borderline category, if there is only one anomaly, we consider this as normal. If there are 2 anomalies, they go into the abnormal category. I'd like to just talk a little bit about the abnormal category. This is T-wave inversion beyond V2 in adult white athletes, ST segment depression, pathological Q waves, complete left bundle branch block, an interventricular conduction defect of more than 140 milliseconds, ventricular pre-excitation, long QT interval, and the Brugada ECG pattern. This ECG pattern of widespread T-wave inversion is abnormal in every case. In fact, in our experience, if we find this ECG in a white athlete, there's a 60% chance we'll identify a cardiomyopathy or myocardial scar. In black athletes also, even though they do have a higher prevalence of T-wave inversion, this ECG would identify a serious cardiac fault in approximately 20% of individuals with this ECG pattern. So the new international recommendations, which are due to be updated, have reduced the number of positive ECGs in white athletes down to under 3%. They've maintained sensitivity for diagnosing serious disease at 92%. They've also improved specificity for diagnosing serious disease from 87% to 97%. And the positive predictive value of an abnormal ECG is 17%, suggesting it's a good screening tool. What about the cost of false negatives? It's important to emphasize that ECG and history and examination will fail to identify certain things such as anomalous coronary arteries, adrenergically driven ion channel disorders, and incomplete expressions of cardiomyopathy. They will also fail to identify atherosclerotic coronary artery disease and other acquired diseases such as commotio cordis, myocarditis, and electrolyte disorders. Therefore, symptomatic change, the change in symptomatic status is important, and if an athlete has screened normal and develops symptoms, they should be screened again. What about cost? Again, there is a cost associated with screening. As we have improved our ECG interpretation from the 2010 ESC recommendations to the more recent international recommendations, this has resulted in a 27% cost reduction, which is massive, but it does mean that it cost us about £26,400 to identify a single athlete with a serious condition. Now, it's contentious whether this is worth it or not, but if we think about the amount of money we spent on the billions and billions we spend on our octogenarians, I believe that my personal view is that we should be willing to spend £26,405 to identify one athlete with a potentially serious condition, because minimal treatment could give back decades of life. Then there are, of course, other issues. This includes differentiating physiology from pathology. This usually affects black athletes with left ventricular hypertrophy and white athletes who've got big ventricles, white endurance athletes who've got big ventricles with slightly lazy ventricles, raising the possibility of dilated cardiomyopathy or arrhythmogenic cardiomyopathy. And to do this, we need multiple experts, we need a good infrastructure, and I think that could be one of the other limiting factors if we promoted screening for every single athlete. So how do we identify middle-aged individuals? If we look at deaths in the community, the blue bars represent the recreational athletes and the red bars represent the young competitive athletes. The blue bars, you'll find death rates in the blue bars are much, much higher. These are recreational athletes, and you'll see that most deaths occur in males, 20-to-1 ratio compared to females, and most deaths occur in people aged 45 to 55 years old. 90% of these deaths are due to coronary artery disease. So how do we identify those people? Because exercise may cause plaque rupture due to metabolic factors, shearing forces, activation of the hemostatic system or high catecholamines, or it may cause demand ischemia, but the end result may be ventricular fibrillation. So identifying high-risk individuals, we adopt a very pragmatic approach that relies on symptoms, habitual activity, and the 10-year risk score based on the score chart that takes into account smoking status, blood pressure, and the total cholesterol. And individuals with a risk profile of more than 5% are considered high risk. We also look at high level of established risk factors, such as a 10-year risk of adverse event exceeding 5%, a history of diabetes, a blood pressure more than 180 over 110, a total cholesterol of more than 8, a family history of premature cardiovascular disease in a first-degree relative, or a BMI of over 28. If someone has a low cardiovascular risk score and has no symptoms and are physically active, we don't recommend any further investigations, and these individuals can exercise and compete in whichever sport they wish to. However, if someone is considered at high risk or has additional risk factors or have been sedentary and want to engage in high or very high intensity exercise, we recommend an exercise stress test, a functional imaging test, or a CT coronary angiogram to check for significant coronary artery disease. If individuals have high-risk features, we recommend invasive coronary angiography with view to revascularizing before these people can start competing again. If invasive coronary angiography doesn't show significant disease, they may continue as usual. It's important, though, that we may not be able to get to most of these people, and therefore cardiopulmonary resuscitation is essential, and someone else will be speaking to you about this. But if someone just watches an arrest and alerts someone for help, then the odds ratio of someone coming out alive is about 2.5-fold. If someone actually starts bystander CPR, then you increase the survival rate by 3.8-fold. If an early AED is applied, then the outcome is improved by 5.2-fold. Here's the survival rates from some of the public races. You can see that survival rates are far, far better than they are in the community, ranging from 23% to as high as 93%. And this, I go back to the video of this chap that arrested. He had a reveal device in situ. So he's gone down. He goes down at 16:15. You'll see 3 VEs that degenerate into polymorphic VT and into ventricular fibrillation. And within 2 minutes and 40 seconds, sinus rhythm has been restored due to very early pitch side care and very brisk pitch side care, which is absolutely essential. Education is also important. We ask individuals not to exercise when they've got a febrile illness. We ask individuals to abstain from performance enhancing agents. Those with long QT syndrome should avoid specific medications. Those with atherosclerosis should pay particular attention to risk factor control. And this slide shows that in a study of middle-aged individuals that had cardiac arrest, 16% had pre-existing heart disease, 56% had one risk factor, and 36% had typical symptoms prior to the race. So exercise is a risk factor for sudden cardiac arrest and myocardial infarction in predisposed individuals. Relatively simple screening methods can identify a large proportion of adolescent and adult athletes with serious cardiac diseases. The evaluation of an athlete requires knowledge of the cardiac adaptation to exercise to facilitate the differentiation between athlete's heart and cardiac disease. Sudden cardiac death during sports is most common in middle-aged and older male athletes and is most frequently due to coronary artery disease. Identifying high-risk middle-aged or older individuals requires a pragmatic approach to check for symptoms and risk factors for atherosclerosis. Thank you very much for your attention.
Thank you, Sanjay. A powerful talk, many lessons which we'll discuss afterwards. Again, please put your Slido questions in. I can see them coming in and we'll be discussing those in 2 talks' time. It's a great pleasure to welcome now Professor James Hull. He's the clinical lead for respiratory medicine here at the Institute of Sport, Exercise and Health. And he's the clinical lead for chronic cough and unexplained breathlessness at the Royal Brompton Hospital, which has clearly an international reputation. He specializes in helping athletes with respiratory symptoms, currently working with the International Olympic Committee and the UK Sports Institute as their respiratory expert. Of course, the heart and the lungs are interconnected as a cardiorespiratory system, and so therefore he's going to be discussing assessing respiratory issues as a cause for collapse in the athlete. Thank you, Jim.
Well, thank you, Matt, for that very kind introduction. It's lovely to join you on this symposium this evening. And of course, as both a clinician, but also a spectator and someone who enjoys watching sport, it's always alarming and, of course, a challenge when you see an individual who's collapsed in the context of sport. Obviously, there's a concern from my perspective to determine if there is a respiratory or pulmonary cause for that collapse. And that's the issue and the area that I'm going to cover in my section of this talk. So when an individual collapses or becomes pre-syncopal in the context of physical activity, there's obviously a primary dysfunction at a cerebral level. There's a central problem that has caused the system to shut down. And you've heard over the course of the talk or the talks that are going to come, the different types of problem that can cause this issue. Imbalances in the type of substrates which are feeding the brain, electrolyte imbalance, problems with blood sugar, problems with thermal issues, problems with circulation and the blood flow to the brain. But in the context of my talk, what I'm going to discuss is how pulmonary issues may also contribute to a shutdown centrally and then the resulting pre-syncope or syncope. What I want to do over the course of this talk is cover 4 real issues or questions. First of all, as a clinician or someone who is involved in the care of individuals in a sporting context, when should you consider a pulmonary cause of collapse or near collapse? Secondly, of course, what is the main differential diagnosis in that context from a pulmonary perspective? Third, how might you proceed for assessing that individual? And then finally, to touch on very briefly and give you some overview of what you might do next in terms of treatment. I want to start by introducing a real-life athlete that I looked after a few years ago. And this is very typical of the type of case that I see in the sports pulmonology service at the ISEH in central London. And I want Rebecca just to describe some of her symptoms and some of the issues. And she had episodes of collapse and pre-collapse or pre-syncope in the context of rowing-based exercise. So we're going to hear from her now what her symptoms were like.
My name's Rebecca and I'm a rower. I row in a quad and I did Junior England 2 years ago.
And a quad is?
4 people rowing with 2 oars each.
When did you notice that you had a problem?
I started training properly in my upper 6th year, and I started every time we were racing, I'd have problems breathing and sort of get rushed off to an ambulance at the end of every race.
And the feeling is of shortness of breath? Are you coughing?
Shortness of breath. It felt almost like someone was strangling me or like choking me. It just really hurts. I went to my GP, who referred me to a chest specialist, who tried me on pretty much every combination of asthma medicine.
The presumption was at this stage that you had asthma?
Diagnosed with asthma at 15, so they just assumed it was the same problem. The last race that I did, got to the end and I took all my asthma medicine and it didn't help, and then they put me on an oxygen tank and it took like 2 hours almost to calm it down.
But outwardly to other people, presumably it looks like a classic asthma attack.
Yeah. My name's...
So a fairly classical description, and one that I'll see or listen to many times in the clinic over the course of a typical clinic. And of course, in the clinic, you're often some way distant from the episode when people are describing the symptoms to you, and you're having to try and work out what might have caused that acute presentation. And so I tend to obviously start by just describing or discussing some of the issues and in conversation with an individual. And I'm really focusing to try and determine whether there was a focus on the pulmonary system or ancillary features, which I'll touch on later on. And for instance, whether there is focal aspects within the chest, as opposed to more general symptoms, which may indicate a cardiological cause for collapse. Often, of course, it's helpful to have a description of the clinical features or a witness report of the attack. And that might, of course, include symptoms such as visible respiratory distress or the presence of wheeze or inspiratory wheeze termed stridor, evidence of swelling in and around the face or rashes, and whether, for instance, someone's coughing up secretions, whether they looked pink and discolored. And I'll talk about that in the context of the differential diagnosis in a second. If people are having recurrent episodes of presyncope or collapse, then providing it's safe to do so, it can often be insightful to try and obtain a video footage of what occurs in the context of those episodes. Sometimes the nature of the wheeze, as you'll see in a minute, can often inform the differential and can help move forward with the diagnosis. But what I say overall, in terms of the take-home message here, is that if there aren't respiratory localizing features, it's unlikely to be a pulmonary cause of that collapse. And so, for instance, if an individual suddenly collapses in the field of play and there's no preceding breathlessness or wheeze or other features, it's very unlikely that the cause of that problem is something like, for instance, acute laryngeal closure or acute asthma as a cause of collapse. So what is the main differential diagnosis that I consider in the context of pulmonary cause for collapse? And again, if we return to the model which puts the brain, of course, central to the mechanism which causes collapse, by and large, the most common explanation that I'll see where people feel dizzy, or they feel as though they're going to collapse, or they get to the end of an event and they feel as though they're going to pass out and then can be disorientated, relate to conditions where the carbon dioxide level in the blood has been reduced, and yet there is a normal oxygen level. Whereas in contrast, a far less common explanation is a drop in oxygenation and then some compromise in ventilation where, for instance, the carbon dioxide level is increased. And so, very classically, acute or acute on chronic hyperventilation can cause people to feel very dizzy and often to collapse to their knees or fall to the ground. And that hyperventilation might arise secondary to other causes, such as a closure of the voice box in the context of vigorous sport, or indeed in the context of a near asthma attack or an asthma attack, where people are really breathing very hard and their carbon dioxide level starts to drop. In contrast, in conditions where there is true compromise of the pulmonary system, for instance, a pneumothorax or a blood clot on the lungs, or for instance, pulmonary edema that develops, for instance, in the context of swimming, there may be compromised ventilation and then a drop in the oxygen level with a low oxygen saturation. Likewise, if there's compromise, an acute compromise to the airway, you could get a ventilatory compromise, for instance, if there's acute swelling within the airway. And I'm going to touch on some of those causes in a second. It's also worth recalling that the so-called respiratory muscle metabolar reflex. This is described by Jerome Dempsey and Lee Romer. And in essence, a number of elegant physiology studies demonstrated that if the respiratory muscles become very heavily loaded, then there is a reflex which slows down the output to the exercising skeletal muscle, and that slows people down and gives them leg discomfort and will stop them from exercising. Of course, this usually plays out in a much more subtle form where people feel fatigued and it reduces exercise performance. But acutely, if you get very acute respiratory embarrassment with loading, there is an immediate shutdown which will stop people from running or exercising and make their legs feel like jelly, and often they'll collapse to the ground. It's one of the mechanisms alongside things like a low carbon dioxide level, which may explain why people become pre-syncopal with pulmonary compromise. So in the clinic, when I see individuals with exercise-associated respiratory symptoms, obviously I'm going through a sort of work through pretty typical way of taking a clinical history. If you want more information in this area, I'd urge you to have a look at the British Thoracic Society clinical statement on the assessment and management of respiratory problems in athletic individuals, published a couple of years ago, which I was very fortunate enough to chair with some excellent colleagues. But essentially, we walk through some of the different conditions that can cause problems. We look for red flag issues, such as conditions where people might be coughing up blood or get acute and focal chest pain. And you can read through that in the document in more detail with respect to these different conditions. Having said all that, the key point in this document is to highlight that for most, certainly young individuals who are otherwise fit and healthy, who develop acute respiratory issues in the context of sport, the differential diagnosis comes down to one of three conditions. Either asthma, a condition called exercise-induced laryngeal obstruction, where the voice box becomes compromised in the context of vigorous exercise, or this disorder called BPD, or a breathing pattern disorder. And so most often in clinic, when I see people who have said they've become compromised at the end of a race or when they've been performing very vigorous exercise, usually I'm looking through the red flag kind of conditions, but then I'm typically working through these three differential diagnoses to try and come to a clear diagnosis and a plan. I want to show you a video of a typical case of an individual coming in from a run with some degree of respiratory compromise. And I hope you could hear the clear and evident wheeze and a localization of the symptoms to the upper airway. And in the collapsing athlete or the athlete suffering with a pre-collapse, often you'll get a history of someone who was, for instance, in a rowing boat where people could hear a wheezy noise that was very loud shortly before someone collapsed, or someone felt very faint and then nearly collapsed. It's often useful to try and interrogate the onset of symptom and when symptoms are most intense. And so there may be a time course where symptoms are maximal at the peak of exercise intensity. There may be a time course where actually people start to feel compromised, stop exercising, and in fact it becomes worse in the 30 minutes following exercise. Or there may be a very variable pattern to the onset of breathing symptoms. It's also useful to try and work out if anyone had localizing symptoms in their chest, where exactly those symptoms arose from. Did they arise in the throat? Did they arise lower down the chest? Or were they more diffuse? And actually what that does is it helps shape out the differential diagnosis of those three key conditions that I described earlier. This condition ILO, where the larynx is closing and the symptoms localize to the throat, and the symptoms occur at the very peak of exercise intensity at the end of a boat race, for instance. EIB, where the symptoms might be lower down the chest, but actually the symptoms worsen when people stop exercising, and this condition, breathing pattern disorder. I should just clarify that EIB stands for exercise-induced bronchoconstriction, or breathing pattern disorder, where the symptoms are somewhat variable and can be associated with tingling in the hands or other features of more general hyperventilation. Having said that, and focused on the three key and most common differential diagnoses, there are other causes for this problem, for this type of issue. And one key consideration is the condition called exercise-induced anaphylaxis, often associated with the ingestion of wheat product in the 30 minutes or hour before people exercise hard. And if you look at the clinical ancillary features, you can see from these two important papers how common it is to have itching or some degree of urticaria, or what may otherwise be described as hives in individuals who get these symptoms. And so if someone has collapsed suddenly and they've been breathless or they've been wheezy, it's often worth determining whether there are these ancillary features which may point to exercise-induced anaphylaxis. I should add, an incredibly rare condition, but important that it's detected and thought about. The other rare but important differential diagnosis is swimming-induced pulmonary edema, a condition that both Matt and I wrote an article about several years ago, which summarizes some of the key points and considerations in this condition. But very classically, this is an individual who's partaking in, for instance, a triathlon event, and they're in a wetsuit, and they suddenly become very breathless during the swimming event. They're pulled out of the water or climb out of the water and are very acutely distressed with breathing difficulties, with a cough, and often producing or coughing up pink or frothy secretions. And actually, the condition starts to settle when they come out of the water, or typically resolves very quickly after administration of oxygen, and usually settles before someone gets to hospital. If they do have such a severe attack that they have a chance to have an X-ray performed in a hospital setting, you will see the classical features of fluffy infiltrates, as you can see on this X-ray, in keeping with pulmonary edema. So what next in the assessment of individuals? Well, I've talked through the clinical assessment. It's vitally important in the context of pulmonary issues that people get decent, objective clinical assessments with tests which assess, for instance, pulmonary function. And at the ISEH and the Sports Pulmonology Service, we have a number of different tests that we do in terms of tests for lung function, tests that are very good for determining whether someone has exercise-induced asthma, and other tests, which I'll show you in a second, that determine if there is a degree of laryngeal compromise during vigorous exercise. I say all this because we know there is a poor relationship between the presence of symptoms and objective test diagnosis, and therefore objective tests are really important to make sure that the diagnosis is correct. This is a common test we do, which is called a continuous laryngoscopy during exercise test, where we will have an individual exercise in a modality which causes their symptoms either on a bike or on a treadmill, put a laryngoscope in situ, as you can see, and then ask an individual to exercise vigorously so we can see what happens to the larynx, which you can see on the video just behind them. It gives us a continuous view of the larynx. You done?
Yeah.
To diagnose a condition called exercise-induced laryngeal obstruction, and here's a static image of someone with that condition where you can see an infolding of the structures around the larynx, which literally reduces the inlet into the trachea down to the level of the size of a straw. And people often say, it feels like I'm breathing through a straw. And it's often associated with a compensatory hyperventilation, which then causes people to feel dizzy and pre-syncopal, and on occasion to collapse. And of course, when an individual collapses with this condition, there's a very loud wheeze and distressing. It's very distressing for people around who think it's a very severe or so-called brittle asthma attack. Often I say to people, and as I alluded to early on, it's useful to have some video footage of what happens in the context of someone developing symptoms. Of course, it isn't safe to do that if people are collapsing or having very serious events associated with it. But if there is a chance to explore symptoms in the context of more moderate exercise and to record what it looks like on a video phone with a selfie or with a family member or coach around, that can provide useful insight for the clinician assessing the individual. Of course, the individual needs to be put under physiological stress in order to see what happens at that time. And so I'm often saying to people who develop wheeze, certainly, or breathlessness, that it's useful to take a video recording and then show that to your clinician. And a diagnosis of ILO is often overlooked. And if you recall the video that I mentioned at the start with a case report of Rebecca talking about her symptoms. Her ultimate diagnosis was of exercise-induced laryngeal obstruction, the voice box closing in and causing it to have those collapsing events, which were treated as asthma and with oxygen, but actually responded very well to treatments targeting exercise-induced laryngeal obstruction. So my final couple of slides are just to talk a little bit about treatment. Of course, there isn't sufficient time to talk through the management of all of these differential diagnoses. But what I would say, of course, is that when someone collapses, it's incredibly distressing, not only for the athlete who's had that episode occur, but everyone around them, particularly if you're in a team and that individual is having regular pre-syncopal or dizzy episodes. It's important it's taken seriously and that these individuals are treated and supported to help them perform their sport and feel comfortable and safe doing so. The immediate treatment will be covered in other talks this evening, but of course often the default position for people who are wheezy and breathless and collapsing is to treat this as asthma, and that often entails, of course, nebulized treatment or oxygen treatment, and that's the right thing to do in the context from a safety perspective. But of course the next step is to try and work out what to do if that treatment isn't necessarily the right way forward, or if there aren't ancillary features of asthma. And I always start by saying that the important thing is to get the diagnosis right as number one, so that you can move forward and use the correct treatment and try and avoid further episodes. Of course, number two is to get the diagnosis right. And you can imagine what my third point is in terms of treatment, which is getting the diagnosis right, because everything follows from a correct diagnosis. And if you suspect someone has brittle asthma or is having acute severe asthma attacks every time they do a cross-country run, and in fact the diagnosis is exercise-induced laryngeal obstruction, then of course you're never going to try and help them, and using inhalers to try and treat that condition isn't going to be beneficial. Often treatments that we use at the ISEH actually lean into treatments targeting functional breathing control. And if you remember that most of the causes of dizziness or dizziness in the context of exercise occur in the context of a low carbon dioxide value, then our MDT, and particularly Julie Moore, who leads our respiratory physiotherapy team at the ISEH, have a great deal of success in terms of controlling those tendencies towards low CO2 values and then improving and controlling the chances of people getting pre-syncope. And so when we've got the diagnosis right, we can then use multidisciplinary team expertise to try and help avoid further episodes of collapse. So what are my main take-home messages in the context of extreme pulmonary issues in the athlete, those causing collapse or pre-syncope? Well, first of all, when should you suspect a cause? Well, I think it's only important to consider this if people have localizing features or video footage which suggest that there is a wheeze or other features which prompt consideration of pulmonary issues. And of course, that may include the findings that arise from challenge testing as that's appropriate. The main differential diagnosis, I think, for athletic individuals feeling dizzy or pre-syncopal and possibly syncopal in the context of exercise will relate to a low carbon dioxide value. They're functional disorders. There are some rare causes, but they are usually catastrophic in onset. And there are other features which sit with this. And I've already explained some of those key differential diagnoses. Certainly, if someone says there's been a loud wheeze before someone collapses, rather than thinking about asthma, I would strongly suspect you think about whether that's coming from the upper airway and this condition, exercise-induced laryngeal obstruction. It's important that individuals undergo objective tests to really confirm and make sure that a diagnosis is secure and that history isn't just based on symptoms alone. And finally, treatments are often specific, of course, depending on the particular diagnosis. Therapy-based approaches are often very effective in the context of functional disorders of the pulmonary system causing collapse. Thanks very much. These are my contact details. A plug for the textbook we've written in this area, and of course the British Thoracic Society guideline. And please feel free to contact me if you have any patients or individuals you'd like to discuss with this type of issue. Thank you very much.
Thank you, Jim. Very insightful. Audience, please continue to submit your questions to us via Slido. I can see them coming in now. A great one on CO rebreathing. We'll tackle that one a little bit later on. And so we move on to Doug Casa. So in Olaf's risk strategy profile was looking at cardiac arrest. Then we've moved on to respiratory, and we're now looking at warm environments. There's no better man to speak on this topic than Doug Casa. He's the CEO of the Corey Stringer Institute, which I'm sure he'll talk about in a moment about how it was set up. He's a distinguished professor of kinesiology at the University of Connecticut, which is set up to provide research, education, advocacy, and consultation to maximize performance and optimize safety to prevent sudden death in athletes, warfighters, and laborers. It's slightly different over there in the US. He's a licensed athletic trainer, but he's treated over 405 cases of exertional heat-related illness with 0 fatalities. He's an expert member of the Tokyo Games, and as you recognize that Tokyo was a very hot Olympics, as is many future Olympics, in all fairness, and was part of the committee that helped adjust the time schedule of many of their endurance events. Doug's going to be concluding tonight on looking at exertional heat stroke in a warming climate, prevention, recognition, and treatment. Thank you, Doug.
Hello, everyone. I'm Douglas Casa. I'm a Board of Trustees Distinguished Professor at the University of Connecticut and also CEO of the Corey Stringer Institute, which I'll explain in a few minutes. And I'm excited to give this talk, Exertional Heat Stroke in a Warming Climate, Prevention, Recognition, and Treatment, and Considerations for the Laborer and Athlete. The Corey Stringer Institute mission is to provide research, advocacy, and consultation to maximize performance, optimize safety, and prevent sudden death for the athlete, warfighter, and laborer. We were founded approximately 15 years ago. Some of you may know that Corey Stringer was a former NFL football player in America who passed away in 2001 from an exertional heat stroke. I was asked in 2010 to host the lasting legacy for Corey here to try to have a positive aspect of his legacy in trying to prevent future deaths and optimizing people's situations when they have to do physical activity in the heat. We have 9 corporate partners currently at the Corey Stringer Institute. Some of these you'll recognize, and others that are important in the space of health and safety and performance for these populations. The University of Connecticut, for people who don't know, is an amazing place to work and to live. And if anyone's ever interested in visiting or interested in grad school, let us know. But we're really, really good at college basketball, if that's a big sport for you. We're having won 17 national titles in the last 25 years. So my background stems from having an exertional heat stroke myself back in 1985, so nearly 40 years ago. And that kind of shaped my path and my journey since then. And I have research experience. I've published approximately 400 publications or chapters in edited books. I've also have a lot of experience with clinical care, having been involved with the treatment of 405 exertional heat strokes in 8 different sports. And I've also been an expert witness in approximately 80 lawsuits related to heat strokes that occur in the labor setting and in the athletic setting. So those varied experiences of being a researcher, a clinician, but also doing a deep dive and understanding when things go wrong in lawsuits has really shaped my perspective, and hopefully that's helpful today for us. Just a very brief look at some of our experiences. We assisted the Portugal national team before for 6 months before the 2014 World Cup. This is just a tiny snapshot of some of the experiences. For about a 10-year stretch, we helped U.S. Soccer in America develop a lot of the heat policies for our youth soccer programs in America. The U.S. women's national team came to our labs for the 2 weeks before they left for Tokyo so that they can get heat acclimatized and be fully prepared when they landed in Tokyo to prepare for their games during the 2021 Olympic Games. So that was exciting. I've also assisted the country of Qatar when they were hosting the World Cup in 2019 and the World Cup in 2022 with their medical staff, and also with the track and field world championships, also with the planning of the events related to the climate of different times of the day. Also is very involved with a special work group that the International Olympic Committee put together in 2020, or they put it together in 2018, to prepare for the heat that they anticipated at the Tokyo Olympics, and originally in 2020, but due to COVID in 2021. And that turned out to be the case. It was the hottest Summer Olympics in history. We worked for 3 years to prepare the staff, the medical staff, so they'd be prepared to prevent and treat exertional heat stroke. But we also were very intimately involved with the organizing committee on the scheduling of events to optimize safety for the athletes. An example of some of the work we do in the laborer space, these are just an example of some of the organizations that we've assisted, and there's many more where we provide a lot of their heat mitigation strategies for these companies who have hundreds of thousands of employees who have to do their job in the heat many of the days that they're working. This is an example of some of the publications we've published recently in the laborer space. Gives you a snapshot of the different work that we've done, either related to productivity, safety, the research being done on men versus women, the economic impact of workers being in the heat, and things like that. But importantly, when we talk about stuff, a lot of the people in the audience right now, I'm guessing, have experience working for sports science and working with athletes. But this hugely emerging space having to do with performance and productivity and safety for the laborer, keep in mind there's hundreds and hundreds of millions of workers in the world every single day who have to do their job in the heat. But we can't just simply apply what we've learned in the athletic setting and assume that that's going to be applicable in the laborer space. And there's a lot of reasons for that. Generally speaking, the athletes don't have other medical conditions. So comorbidities is a massive issue in the laborer space, because you have people who have other medical conditions. You have workers between ages 20 and 70. They often on many medications for those different other comorbidities. They're also working 12-hour shifts often versus an athletic population might have an hour event or a 2-hour event or a 2-hour practice. There's very little data on female laborers. In fact, less than 10% of all the data we have on laborers are related to females. There's a lot of issues related to unions and immigration status. The stakeholders are different, the issues related to productivity, variability with schedules, and the fact that you can't change schedules in a lot of work settings that are outside where you need natural light to do the job. So anyway, there's just a lot of issues that you really have to consider the occupational space as a unique entity and not assume that some of our learnings from athletics are just easily applied in the laborer space. Just some other things related to that. A couple months ago, I was in the White House by invitation of President Biden and his Secretary of Health and Human Services, looking at how to improve health and safety in the laborer space. We've been working very hard with this administration over the last 4 years to develop a federal heat standard, which does not exist in America. There's recommendations right now, but to have a specific standard to try to enhance health and safety for laborers. Specific to University of Connecticut, to give you an idea of a couple of things I'll talk about today, we have a beautiful heat lab where a lot of this work gets done. We also do a lot of field research where we're with people in their natural settings. We also are building a new $1 million heat lab that's just started construction this past week, and that's going to be open next year. And this is just an example of the exciting new heat lab we're building right now. But importance in this labor space down in Jacksonville, Florida, where people have to deal with the heat every day in their work setting, we're building another Corey Stringer Institute facility so that we can study the labor in their natural work setting in the field setting, but also bring them into the laboratory nearby to look at other more in-depth analysis. So this is extremely exciting that in the next few years, we'll have this state-of-the-art heat lab being built, but this coming fall, we'll actually have our first heat lab already built there. So why this all matters is that you're all aware that obviously climate is getting warmer. Global warming is happening at a much faster rate than anyone had anticipated. And you can look at heat wave frequencies. That's just in my lifetime. Born in the 1960s, here we are in the 2020s, and heat wave frequency has tripled. Heat wave duration has gone up by 25%. Heat wave seasons has more than doubled. The intensity of heat waves has gone up. So you can see that right there. And you keep in mind, just in America, there's 8 million high school athletes, another million college athletes. And in the military, there's over 1 million warfighters that we have. We have over 100 million people who have to do work, some kind of work in the heat at some point during the year with their job. And as I mentioned before, there's no standards. And the guidelines sometimes are very technical and not feasible. So recently, the International Labor Organization produced this. In fact, this just came out in the last couple months, and it gives you an idea of the increase. And I highlighted like your region in Europe, regions with the most rapidly increasing workforce exposure to excessive heat since 2000. So just in a 25-year stretch, a 17% increase in that heat exposure for your workers. And in North and South America, you can see a 33% increase. But that is just an example of some of the work that's happening and the changes in the number of workers that are at risk. So an example of some of the work we've done recently, only 21 out of the 1,500 studies that we found related to laborers involved involved women. So 91.5% of all the male study participants have been male. And over 95% of them have been healthy participants, which is just not very practical in the labor space where people are in their 50s and 60s very often and have a lot of other comorbidities that have a huge influence on their exercise heat tolerance. Also, many of these studies have been in a laboratory setting, which is, again, probably not super realistic for what a 12-hour work shift might look like and some other stresses. So this is a picture here, a pie chart, an example of some of the look where you can see that over 90% are involving men. And in the labor space, at least in America, about half the workers are women who are working in the heat. But as you can see here, less than 9% of the research we've done have included women. Another recent study that came out that I think is fascinating, that just came out last year in January of 2024, work to rest regimens in hot environments. And here you can see this extremely interesting figure here, looking at the number of studies that, for instance, look at core temperature, effort perception, thermal perception, skin temperature. And those kind of make sense if you're doing work in this area. But if you look on the right, they have data that corresponds with the data that we recently published, that almost all the studies include men. Almost all the studies are in a lab. In fact, only 3 of the studies were field studies. And then almost all of them included unacclimatized people, which, people who do work setting in the heat every single day often are probably becoming acclimatized or at least partially acclimatized. And here you can see the age populations on the right. Almost all of them are between 20 and 29, and that's just a tiny percent of the people who have to do work in the heat. And most of them are in a body mass index that would be considered healthy. And again, most laborers' body mass indexes are much higher. So this reminds us that all the way back in 1969, the World Health Organization published a document for best practices for health factors involved in working under conditions of heat stress. And a lot of the report of that WHO scientific group are the same things that we're recommending right now. And unfortunately, there's been very slow progress. So it's a document I'd recommend that you look at to give perspective that this has been considered for quite a while. Similarly, just last year, a research study looked at a systematic review and some recommendations, and specifically trying to increase our understanding of what happens with women laborers, both in indoor and outdoor work environments that are in the heat. So very specific considerations that you have to consider for women that have really almost never been considered before in other studies. Here at the University of Connecticut at the Corey Stringer Institute, we led an international effort to have a best practice document for heat safety in the workplace. And this was published in 2021. Dr. Maggie Morrissey led this effort, this Delphi effort, where we considered everyone's thoughts and opinions and perspectives and put it together in this document and came up with 8 different aspects that people need to consider if they're supervising people who are laboring in the heat. And so there's something that I would recommend that you access. It's publicly accessible at GeoHealth. The 8 different aspects that we have people considering are heat hygiene, hydration, heat acclimatization, environmental and physiological monitoring, body cooling, personal protective clothing, equipment, and emergency procedures. I do not have a time in my 20 minutes here today to go over all of these items, but I do want to make note of it because I think you'd find it super interesting that there's a very deep dive on each of those 8 items. I will take a snapshot of a couple of these. So within that document, when we published that in 2021, this document has been used as the grassroots foundation for a lot of things that's been happening in America. So for instance, the OSHA proposed federal heat standard that I've just mentioned, this has been served as a building block. The ANSI voluntary standard, NIHHIS National Heat Strategy document that came out recently for the next 6 years for a strategy for that, the UN call to action, and mobilization for key occupational safety organizations to create resources. All of those items utilize this document that came out in 2021 because it was really one of the first best practice documents that really considered these multiple aspects of the labor of being in the heat. So when we talk about prevention in general, which is, a big component of that GeoHealth article that I just mentioned, there's a lot of things to consider, and you often can strategize and compartmentalize them between intrinsic and extrinsic risk factors. So intrinsic would be things like your hydration status, if you're taking certain medications, if your fitness level, your acclimatization status. Those are all be things like intrinsic risks. Extrinsic things could be like, is there water that's accessible? Is there shade during breaks or during work that you're performing? Is there airflow? Is there other things like that that people can provide in their workspace, work setting, to make it safer for them, and also obviously reduce the incidence of heat illnesses. So to take it further, we have to also remember in the laborer space that a lot of times laborers are in more remote circumstances. It's not like a lot of colleges or high school sports or pro sports, especially in America or probably worldwide, that are often in cities and towns that have access to hospitals and medical care. So something you may not be aware of, but in the world of exertional heat stroke, which is a leading cause of exertional death for laborers around the world, and one of the 3 leading causes of death for warfighters in training and athletes, you have to, if someone has a heat stroke, you have to get their body temperature under 104 degrees, which is 40 degrees Celsius, within 30 minutes of presentation of the condition if you want to assure survivability. So we did a study here in America to look at access that laborers had to the medical care. And so what we found that the odds of laborers dying from heat stroke were 3.7 times higher in states without the appropriate standards for cooling on-site and transporting second. I'll give you a quick, super quick snapshot. There was a place in America that I recently visited that it would take 4 hours to get to a hospital if you called, because it's 2-hour drive there, 2-hour drive back, thousands of people working in this oil and gas facility. So that particular place would need a strategy to cool their people on site because they cannot rely on either the ambulance or the hospital to provide that care. Something similar, we're also people around the world, scientists are looking at the role that dehydration has on kidney function, very specific to laborers because you have these 12-hour work shifts, and you're chronically dehydrated, and they're not just the acute influence of like a heat stroke, but now what happens when you're chronically dehydrated for 10 or 15 or 20 years in a row? What toll does that take physiologically on the kidney and other systems within your body? So there's an example of a study that came out just this past year looking at cashew workers, and they found that there was an increased risk of some of the indicators of potentially that there's kidneys are working harder, or potentially could become damaged for people who are laboring in the heat. An example of some of the other work that we do and that you should be aware of, in the laborer space, Qatar hosted the World Cup back in 2022, but when they first got the bid to host, they didn't really have a good strategy in place to take care of the laborers that were having to build the stadiums, and many of them, countless almost, died from exertional heat stroke. Thankfully, I worked a lot with Amnesty International and Human Rights Watch, and they worked very, very closely to try to push to have proper facilities built, and they did do that. The organizing committee in Qatar did eventually build proper living facilities for these people so that they could have proper recovery and hydration and food when they're not working the shifts, and other things during their shift that could keep them safer. So these are just, there's so many different aspects of labor safety and so many different people who can advocate for their safety. And it takes the collection of all of us as scientists and knowledge-based people in this area to try to promote this safety. One of the studies that had come out actually in 2019 looking at these workers, that there was a massive increase in the likelihood that a person would die in Qatar while building the stadiums. Even though a lot of people accredited these deaths to cardiac events, I can assure you that many of these deaths were exertional heat stroke, or the cardiac events were preventable because the cardiac event happened because of the extreme stress due to the extreme work conditions and the heat that they were being exposed to. So to kind of recap some of the things here in my last couple of minutes, is a reminder here that I mentioned with exertional heat stroke that survival without complications happens in that first 0 to 30 minutes after collapse. So that's why we need a strategy to cool someone fast. And then you could have things that are long-term, which is up to 2 years, or permanent complications to different organ systems like the liver and kidney, cardiovascular function, cognitive function, exercise heat tolerance. All of those things could be affected if you have an excessive number of minutes above 105 degrees, which is about 40.5 degrees Celsius. So the keys to surviving exertional heat stroke is recognizing the possibility of exertional heat stroke as fast as humanly possible, do a rapid assessment looking for cognitive changes, and doing rectal temperature to assess and diagnose, rapid cooling, preferably during cold water immersion, or some other strategy that could be done on site that has effective cooling rates, and then using cool first, transport second. So you cool until they're done cooling, and then you transport the individual. This strategy has shown 100% survivability. This is an animal model showing that survivability drops off precipitously through time. Thankfully, in the human model, it's 100% up through 30 minutes. And one of the studies, and I mentioned before, you can't wait for the ambulance to arrive in a lot of settings, athletic and labor settings. You have to cool them on site. So a recent work that we had done, I mentioned to you before, looking at guidelines, state guidelines. And so we need to make sure those state or your local guidelines, wherever you live, have this cool first, transport second. And these last few slides on the left, you can see that's cold water immersion dropping from 108 down to 104. The middle is rotating cold wet towels or burrito taco method or dousing with cold water. And the right is ice bags on peripheral arteries. So that's why we want to use the most aggressive cooling possible. So this is an example. Right of the red line is different iterations of cold water immersion, amount of body, the temperature of the water, the circulation of water. They could all differ, but the bottom line is you cool very, very fast in cold water. So I want to tell you an incredible study we just published this past year had incidents. We had 454 exertional heat strokes, which is the largest ever reported in the medical literature. And we had 100% survival if they were started cold water immersion within 10 minutes. And you have to do the rectal temperature. You can't just diagnose based on cognitive, because you need the rectal temperature to know when to remove them from the cold water immersion. Because someone could be cognitively fine at 41, but you still want to keep cooling them. And someone else could be unconscious still at 39, and you want to remove them from the cold water immersion that you're utilizing. All right. And the very last slide technically here just shows that not only is survivability key with cold water immersion, but also if you don't have cold water immersion, if you look on the right, a lot of people will survive without appropriate care, but they'll have long-term complications that they'll have to deal with potentially for the rest of their life. Okay, so I'm going to finish up there, say a huge, huge thank you to the Institute of Sport, Exercise, and Health that invited me to give this talk. Truly an honor to be here today. And if you ever want to contact me, my email here is on the slide. Feel free to go to the Corey Stringer Institute website at ksi.uconn.edu, where you can learn more information. So thank you very much for the opportunity, and have a great day.
Thank you, Doug, and thank you, audience members, for sticking around for 2 hours of your evening. And so what a fabulous evening it's been thus far. So I've been working through your questions, and we have all of the panelists and speakers here for a live Q&A. We have about 15 minutes, and so we'll try and go through these. But just for this, the panelists, if you do want to chip in and help support any of your colleagues, please feel free to do so. So let's start with you, Doug, because we've had a few people talk about cold water immersion and the rectal temperature probe, which is obviously a key part of the decision to cool them and then to monitor the cooling and the drop in core temperature and the management of that. How do you overcome the fear of the rectal probe in the community setting? In the professional setting, we get it, but in the community setting where it's so vital, in those 400 athletes that you had in that community race, how did you manage that?
It's a good question. It is sometimes an issue, so it's certainly something to discuss. But when we're providing medical care in a setting like that, the expectation is to do the standard of care, and the standard of care for exertional heat stroke is making sure that we get an accurate core body assessment, and really the only way of doing that that's expedient in the field is a rectal temperature. So we have to forcefully do rectal temperature against people's will sometimes. When someone collapses at a finish line, they have CNS dysfunction, and when provide medical care, we're still going to do the rectal temperature. And I've had times when people have fought with me and their temp's been 42, 43 degrees Celsius, and obviously it was life-saving to make the decision to do that and to get the cooling going right away. A really seasoned person treating heat stroke might be able to know it's heat stroke without the temperature, but no one knows someone's temperature while they're cooling. So you need the temperature no matter what to assess when to get them out of the tub. So it's just a core element of providing the medical care for that condition.
And so if I put myself in as I'm a voluntary rugby coach, we don't do too much during the summer, but just say we did have a community game, it's not an organized medical event. If we don't have access to rectal probes, is the next best thing providing cooling baths, cooling facilities in that environment?
So I should have clarified. The rectal temperature would be done by a medical professional. Like in America, it's our team physicians or our licensed athletic trainers who are, trained to do those rectal temperatures. If it is in a high school or youth setting, and you suspect someone has an exertional heat stroke, I mean, they've collapsed during intense exercise in the heat, and you've ruled out the other obvious reasons why someone would have had that happen, I would just cool them until medical care arrives. So rotating cold, wet towels, dousing in cold water with a hose, using a cold water from a shower, anything like that, or I would cool them until other people who have more advanced care arrive, but not lose those minutes while you're waiting.
Fantastic. And then just following on, if I may, whilst we have you, the athletes that wear protection. So obviously you've got NFL athletes over in the States, but we do have athletes that wear protection. We've got military that are wearing body armor.
Mm-hmm.
We've got firefighters that have got regulators and heat protective equipment. Obviously that they're working in incredibly hot environments. How do you prepare someone to operate in those environments when the environment outside, like today, for example, is very cold? How do you prepare that operative to work in that challenging environment?
Yes, that's a good question. We work with in America, we work closely like with UPS and Delta Airlines and a lot of other companies. And we found the best strategies are certainly phasing in your employees into the stressful work settings, so that if someone normally works in a northern climate and you're shifting them to somewhere that's warm, that you're phasing in their activity, or if it's a new worker or a worker coming back from a vacation or an injury, or you're reassigning their tasks, or the intensity is going to be different for certain reasons. Ramping up the work that they're going to do across time, we probably find is to be one of the most protective things for workers. And the other one would be when the environmental conditions are more extreme, is to modify the work to rest ratios so that people have more time to cool down and more time to hydrate. Those would be some of the biggest parameters that we found to help people. Labor space is just so different than athletics and military, because the laborers are often 30 to 70 years old, and they have comorbidities. They're on a lot of different medications. Their heat tolerance is usually much less than your otherwise usually healthy soldiers or athletes.
Mm-hmm.
So we really have to be sensitive to they're not going to be able to tolerate as much, and their shifts are much longer. So we got to really protect them, especially during that first week when they're working in a new setting.
I wonder if I could introduce Olaf and, well, all of you. You're all physicians. The concept of illness prior to an event. We know that we don't really want individuals competing or doing high intensity exercise within 7 days of having a viral event, particularly then going to compete in a hot environment. But what's your key advice, Olaf, to someone who does have a viral event and wants to do a competition? Say they're ill on a Monday and they want to compete on a Sunday. Would you advise it, even if they start to feel better by the weekend?
Well, from a medical perspective, I have nothing to lose if I advise them not to compete. That's probably the low risk advice that you can give. At the end, there's no one size fits all reply to that question, because it can be a mild viral infection, that is vanishing as you described, or it can be a persisting bacterial infection. That's sometimes very, very difficult to tell. So the advice would be, as long as you have symptoms, I would not advise to compete. Definitely not. So there's obviously a difference between low intensity exercise, little jog around the block, or a high intensity competition.
If I could challenge you then slightly. So you are now symptomless for 7 days, and you've got a hot environmental competition coming up. You're not a professional athlete, you're an amateur athlete. Would you still think actually probably best to err on the side of caution, or see how it goes?
I would see how it goes. After 7 days of no symptoms, I would see how it goes.
Thank you. Doug and Sanjay, I just want to pick up your medical director roles and the impact of temperature on time of day for racing. So obviously you spoke about, Doug, about the Tokyo Olympics, but what about community sport? Sanjay, you were involved in the London Marathon and a lot of community sport. Are there thresholds that we should be adhering to, saying actually it's too hot for us to compete outside for a particular intensive game, even for adolescents doing 15, 20 minutes of tag rugby, for example. You know, in London this summer, it was 35 degrees Celsius.
Yes, you're right. And I think the one sport, the couple of sports where, you know, people are forced to play at a very high level in this climate. Let's start with the Premier League. We've had temperatures of 33, 34 during a Premier League game. And we haven't seen any catastrophes thus far, but what we have introduced in the Premier League and in the English Football League is that they break after 20 minutes, whereas there's a 45-minute break at half time. There is a water break at 20 minutes, and clearly then again at half time, and then again in the second half. The question about the London Marathon, we obviously the season is usually April, except for 2 runs where they occurred in October. And in April, clearly the temperatures that our marathons run at is about between 14 and 16 degrees, but we have had a temperature as high as 21, 22, and sometimes even 23 degrees after a very cold patch. And in that situation, clearly we try to mitigate things by having excessive ice, special ice bath equipment in our intensive areas. They're not ice baths, but we have pods that we have now introduced where we can actually immerse people into a sack full of ice and water with a rectal thermistor in situ. We increase the amount of water we've got. We ask people not to wear too many thick costumes or too many layers. And we ask them not to go for personal bests. So this is sort of advice that we give. We've got to be as pragmatic as we possibly can. I can't really talk about what goes on at school level and at college level.
Thank you. Yes, go on, Doug.
I was going to say, I could add on quick too. We have to think how team sports different than individual sports and competitions versus practices, because it's really different. In America, we've had a lot of success. So you might not know, but policies for health and safety for high school sports in America, and there's 8 million high school athletes, they happen state by state. There's no national governing body. So a lot of states, especially in the Southeast, have adopted work to rest ratios based on the wet bulb globe temperature. And in the state of Georgia, for example, they had a 70 to 80% reduction in heat illnesses when they instituted very specific breaks at different thresholds. So longer breaks and more often every hour. So not going towards canceling the practices, but you have more time not practicing. So obviously less time building up heat, more time to cool down, more time to rehydrate, and really, really successful. And it's helpful sometimes not canceling it, because we want to get the heat acclimatization session in, because then they'll be more protected as time passes. So if we can have parameters in the practice that keep them safe that day, then ultimately they'll be safer down the road. That's just one example of like a team sport in practice.
Fantastic. Thank you. We move slightly on now just to some of the respiratory questions. And Jim and Olaf, I'll come to you. So there's been a lot of discussion, and there's been a couple of questions on CO rebreathing. I've been a participant for some of your experience, Olaf, where I've had my hemoglobin mass tested longitudinally for your biological passport. But hemoglobin mass in terms of performance enhancement, 1, do you think it's there? And 2, do you think it's detrimental to respiratory health?
I think we need to clarify there's obviously the method of CO rebreathing that is used to measure hemoglobin mass. And then there's a little bit derived from that, the method of inhaling carbon monoxide, basically to cause an internal hypoxia, basically by blocking the binding sites for oxygen on a hemoglobin to stimulate the hemoglobin production in your body, sort of kind of an artificial altitude training. That has been promoted. There's a few studies who show that it might work. The evidence is not very strong, but obviously that went through the press because it's kind of spectacular. But I think these two things need to be differentiated. Most endurance athletes, like you, will have undergone hemoglobin mass measurements once or more during their careers or during a season, just to see how the impact of altitude training is. And that is not dangerous. Your hemoglobin saturation of or your carbon monoxide saturation of hemoglobin goes up to maybe 6%. And if you think that if you smoke shisha, you know it goes up to 20%. So that is not dangerous. If you inhale carbon monoxide at a certain dose throughout many days, this is what you would need to do to get the other side, this other effect, and you get the dose wrong, that might be dangerous in addition to other toxic effects of the carbon monoxide. That said, there's also ongoing discussion whether this is not already prohibited by the WADA prohibited list, because it's an alteration of the chemical capacity of the blood, which is already on the list. So using carbon monoxide for the second purpose that I described is probably harmful for the health and probably also not in line with WADA regulations.
Fantastic. Thank you. I certainly felt very safe under your care. And then Jim, over to ILO. So lots of chat about ILO, but no actual discussion about what to do how to help ILO.
Well, I mean, the mainstay of the treatment is actually therapy-based. So, I mean, there's obviously not scope to talk about the overall management, but our frontline and main treatment is physiotherapy and breathing-based techniques. And so, as I said, we work closely in an MDT to try and deliver that, and it's often incredibly effective. There is a potential surgical solution as well for certain forms of ILO and those that have remained refractory to physiotherapy. And it's a relatively quick and simple operation to address the problem. So those are our mainstays of treatment.
Fantastic. I'm very conscious of time. If Olaf and any other can chip in, but Olaf, I know you work extensively as a cycling doctor with the female athletes. In terms of REDs and underfueling, is that a moderator for exercise-related collapse, syncope?
Likely, you know, because obviously energy for exercise needs to come from somewhere, and if you underfuel, then obviously your energy demands will not be met, and that can definitely lead to collapses. REDS by itself, you know, in cycling and endurance sport is probably almost as common in male athletes, unfortunately, than in female athletes. So it definitely can play a role for sure for the collapsing athlete. It can be a contributing factor, like many other factors that we discussed tonight.
Fantastic. And if I may, just I'm very conscious of time for 2 minutes, but one thing I just want to wrap up on is Jonny Brownlee, right at the very start, said that after his heat-related collapse, he didn't feel right for over a year. And so therefore, question number one, how should we recover individuals to return to high-intensity competitive sport? And two, are they at greater risk of having a second heat-related illness at a future event?
I can start if you want.
Okay.
I would recommend people look. Dr. Fran O'Connor wrote the section on return to play following exertional heat stroke in the most recent ACSM position stand. It's the last few pages of the document. I think it's the most state-of-the-art information we have right now about getting someone back to activity. I think that case study that you mentioned just before, I think he was hyperthermic for much longer than he needed to be from not being aggressively cooled, and that's why he was out of commission for so long. We test like 30 to 40 people here a year who survive heat stroke, but who are not treated properly to help them decide if they can ever get back to their sport or military duty or athletic, participation again, because of a lot of different systems that could be affected from the number of minutes they were hyperthermic. So a lot of factors to consider when you look at that, but those are just a resource I wanted to recommend for your viewers.
Thank you. What we'll do then, Doug, is I'll get that link and we'll send it out to all the delegates that are in attendance this evening. So on that, I'd like to conclude this evening's webinar. I'd like to thank Olaf, Sanjay, Jim, and Doug for their time, their contribution. And of course, he's not here this evening, but to thank Jonny Brownlee for his time and giving his personal experience. All of this talk has been recorded. We'll edit it so I can get all my ums and ahs out of it, but we'll upload it on our ISEH website. Of course, all of our content is free. We encourage you to disseminate it. If you have any questions about any of the talks, the speakers' emails, we won't share, but reach out to ISEH and we'll put you in contact with the speaker. And I'm sure they'll be very happy to answer any questions you may have. So thank you very much. It's been a wonderful evening and look forward to seeing you at the next ISEH event.
Thank you.